right, now we're in a hepatic coma. That's when you eat protein, it transforms into ammonia, and the liver converts it to urea. That's what's supposed to happen, because urea can be excreted through the kidneys without difficulty, and then until your kidneys get messed up, that is. All right? Now, when your kidneys get sick, you can't even get rid of urea. Now, can you? All right? Now, when the liver becomes impaired, then it can't make this conversion. So what chemical builds up in the blood? Ammonia is going to build up in the blood. You didn't make the conversion, you see, so ammonia is going to build up. And what does this chemical do to the LOC? It decreases the LOC. So we're starting to get minor mental changes, motor problems. The patient becomes difficult to awake because they've got too much ammonia in their blood, right? Right, too much ammonia. Asterixis can occur, and your teacher probably called that the liver flap, all right, where the hands are moving. The liver flap, that's when the hands start to tremor. Well, I guess if your hands were trembling, you might have some handwriting changes now, wouldn't you? Yes, handwriting changes can be one of the very first signs of a liver problem because that ammonia is building up. You can't hold your pen steady anymore, all right? Now, reflexes. If you're full of ammonia, do you think your reflexes are going to increase or decrease? Decrease, because ammonia acts like a sedative. Ammonia acts like a sedative. Now, what about the EEG? Is it going to be fast or slow? Slow. It's going to be slow. In fetor, that's when your breath smells like ammonia. When your breath smells like ammonia. Now, different books describe this different ways, okay? Some books say it smells like fresh cut grass. Well, that smells good, doesn't it? All right? Some books say it smells like wine. But the only times I've ever smelled it, it smelled like fingernail polish remover or acetone. It had an acetone smell. Now, I know that breath is not one of those things you look forward to assessing in your patients, right? Right. But you've got to sometimes. But don't worry, you don't have to get really, really close, because if this person has been in their room with the door shut, you will smell this the minute you walk into the room. There won't be any doubt about it. Many times breath changes can mean systemic disease. Breath changes can mean systemic disease. I mean, think about the patient in diabetic ketoacidosis and the fruity breath that they have, all right? Now, look at the next sentence. Anything that increases the ammonia level will aggravate the problem. Well, the number one thing you think of here is what? Protein. Protein. Now, I've got to ask you a question. Do you agree that liver people tend to be GI bleeders? Yes. Yes, or we wouldn't have put it on your handout, right? Right, okay? Liver people tend to be GI bleeders. Well, guess what? Blood is protein. Blood is protein. So if I'm a GI bleeder and I've got blood in my stomach and I've got old blood in my intestines, protein's in there, right? Because blood is protein. What will that old blood make my serum ammonia level do? Go up. It's going to make my ammonia level go up. Now, let's look at our treatment. You're about to see that we're going to do things to liver people to get that old blood out of their GI tract. Now, those first two drugs under treatment, neomycin sulfate and lactulose, big liver drugs. Big liver drugs. That's the first two liver drugs you should think of when you think of the liver, neomycin and lactulose, because they decrease ammonia. They decrease ammonia. Also, cleansing enemas to get blood out of the GI tract, because you know that blood will do what to my ammonia level? Increase my ammonia level, and we don't want that. Decrease what in the diet? Protein. We've got to decrease protein in the diet and monitor the serum ammonia. You're going to monitor it every day. All right. Now, I've seen people that came into the ER on 3 to 11 about 4 o'clock in the afternoon, and by 11 o'clock they were in a hepatic coma. That's how fast the ammonia level can build up in the body. It just depends on what's wrong with the patient, though. Now, bleeding esophageal varices is next. This is when you have high blood pressure in your liver, like with portal hypertension. We've already mentioned that earlier. Well, this forces collateral or new circulation to form. And this circulation forms in 3 different places: the stomach, the esophagus, and the rectum. And when you see an alcoholic patient that is GI bleeding, this is usually what it is, and there's usually no problem until rupture. Okay? Now, here's the deal. You've got high blood pressure in your liver, okay? That high blood pressure is going to exert back pressure throughout my entire GI tract. Okay? Everybody in here knows what a hemorrhoid is. It's a protruding vessel that's got pressure behind it, and it's just waiting to rupture, right? Yes. Well, a varice is the same thing as a hemorrhoid, but people don't like to think about having hemorrhoids in their esophagus now, do they? No. People don't like to be told that, so that's why they changed the name of it to a varice, because that sounds so much nicer, all right? People don't want to tell everybody they have hemorrhoids in their esophagus. Hey, people don't even know they have these things until one of them blows out one day. So let me show you on the picture what I'm talking about. These varices can start in your esophagus, see, a protruding vessel, and they can be in the upper part of your stomach as well. Well, like I said, people don't even know they have them until one day one of them ruptures, okay? Well, say this one ruptures, well, it's going to drip, 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 drip down here into your stomach, and your stomach's going to fill up with blood, and the patient's either going to pass out because they're shocky, or more commonly, what will happen is this. They start vomiting large amounts of bright red blood. That's how it usually presents to the ER. They start vomiting large amounts of bright red blood, and they're very graphic about how much blood they have vomited. Well, when you start vomiting large amounts of bright red blood, you tend to go on to the doctor, don't you? You don't sit around the house and say, well, should I go or should I not go? You get up and go, all right? So it says on your handout, replace the blood, check the vital signs, check the CVP, give them oxygen. Anytime someone's anemic, you give them oxygen, right? Yes. Now, one drug that may be given is sandostatin. Now, the good thing sandostatin does is it lowers the blood pressure in my liver, okay? Well, that's good, because if we can lower the blood pressure in the liver, then the bleeding should stop. The bleeding should stop. That's what I hope is going to happen. Now, the Blakemore tube. What is the purpose of the Blakemore tube? To hold pressure. To hold pressure on the bleeding varice. We're trying to hold pressure on the bleeding varice. Now, normally the GI doctor is going to come in and put this down. It's put down just like you put down an NG tube, but this one's different because it's got balloons on it, right? Okay, let me show you on the picture how this is going to be done. The tube goes in all the way down into the stomach, and then the doctor's going to blow up this esophageal balloon to hold pressure on these bleeding varices, and then he's going to blow up a stomach balloon to hold pressure on these, and then this down here is going to be hooked to suction to get that blood out of the stomach. So this patient's going to have 3 ports on the outside of the body. Now, when the doctor gets the tube in place, all right, what he's going to do then is pull it back a little bit, pull it back out, because they're trying to pull that balloon up to hold pressure on the upper part of the stomach. And then when they get it pulled up like they want it, they tape it real well, tape it in place. Now, and then what the doctor does is he takes a pen and he marks the tube right at the nari. Okay? And you have to be watching that mark, because if that mark starts inching its way out, what's the tube doing? Coming out. That could be an airway issue in just a little bit. That could be one of the times when you might see the doctor go ahead and order restraints, okay? Because this could be an airway issue, all right? So watch the patient very closely. Watch that tube closely. Now, let's pretend for a second that your patient is trying to pull their tube out. Well, they're hypoxic for one thing because they've been bleeding. You might be dealing with an alcoholic patient too, so they're confused. So let's say that they're trying to pull on it. Okay? Well, the long, skinny esophageal balloon's going to come out real easily, isn't it? Yes, it's long and skinny. It works its way out easy. But what's going to happen when the round balloon gets right here? It's stuck now. A balloon's just not going to pop out of their mouth. So is the patient moving any air? No, they're not moving any air. And this is when they're beating on the side rails now, trying to get some help in there. Hey, the most disoriented person in the whole wide world will suddenly become oriented when they can't breathe, okay? They want some help now. So you go into the room and the tube's hanging out and the patient looks all distressed and frantic. What's the first thing you do? Do you say, how long have you been feeling this way? No. What do you do with the tube? You cut it in two. You keep scissors at the head of the bed. You keep scissors at the head of the bed. And you chop it in two and you pull the tube out. You cut it in two for immediate deflation and then pull the tube out. See, you just reestablished the airway, didn't you? Yes, that's the most important thing. Now, there are NCLEX books out there in the world that will have a little shaded box over to the side that says NCLEX alert. And in the box it will say, never sever the Blakemore tube. Well, now you're all confused. Well, what do I do? Well, if you want to make the NCLEX people happy, you better be cutting it in two for immediate deflation. They do not want you to take time to get a syringe and deflate it. That's taking too long. They want you to do whatever you have to do to hurry up and reestablish that airway. That is the most important thing, and that's the fastest way to do it, okay? Now, mag sulfate can be given as an enema to get rid of blood, Now, why do I want the blood out? Because if I don't get it out, my ammonia level is going to go up. There's neomycin again. Why? To decrease what? Ammonia. To decrease ammonia. Remember the liver drug. Now, it makes your ammonia level go down. Those liver drugs we talked about, neomycin and lactulose, make your ammonia level go down. And a saline lavage to get what out of my stomach? Blood. Right. We got to do a saline lavage to get blood out of the stomach. All right. Now we have ulcerative colitis and Crohn's disease. Ulcerative colitis is ulcerative inflammatory bowel disease. Now this is the large intestine disease, okay? The large intestine disease. Now Crohn's disease is also called regional enteritis. It's inflammation and erosion of the what? Ileum, the small intestine, but it can be found anywhere. It can be found anywhere. Now, with words like ulcerations, inflammation, and erosion of intestines, do you see why we have signs and symptoms like diarrhea, rectal bleeding, weight loss, vomiting, cramping, dehydration, blood in stools, anemia, rebound tenderness, and fever? Yes, because of the ulcerative, inflammatory, and erosion that we have in the intestines, okay? Now, tell your friend what rebound tenderness is. All right, I see you. I know what you're doing to your friend. You're pushing it on their stomach, and then you're letting go, and it hurts. Yes, that's how you elicit the response, okay? What does it mean? If somebody has, if you're checking somebody for rebound tenderness and they have it, what does that mean? Peritoneal inflammation. Peritoneal inflammation. And there are lots of abdominal problems out there in the world where you have rebound tenderness and peritoneal inflammation. We're going to mention some of those in just a little bit. So let's look at our treatment together. Even though they're two separate diseases, the treatment for both is basically the same, okay? Now, first of all, do we want a high fiber or a low fiber diet here? Low. A low fiber diet. I think we're modal enough, don't you? Yes, they're already having diarrhea all the time. We're trying to limit motility. We're trying to limit motility to save fluid. That's the name of the game. We've got to save fluid. And these patients learn really quickly what they can eat and what they can't eat, okay? They need to avoid cold foods and smoking because both of these things can increase motility. That's bad. We're trying to limit motility. Also, really hot foods, temperature hot, can increase motility as well. Some patients will receive anti-diarrheal medications, all right? Only given with mildly symptomatic ulcerative colitis clients. It does not work well in your severe cases. So the anti-diarrheals are only given with mild symptoms, a small case of the disease, okay? Antibiotics may be given, and a really good GI tract antibiotic is gastro2, which is a sulfonamide, okay? Gastro2, which is a sulfonamide. Now, steroids are going to be given to decrease the what? Inflammation. And as we've already studied, you know that when people are on steroids, this can lead to lots of other problems too. All right. In the past, it was once believed that these were psychological disorders, in which that's been proven to be false. But look at it like this. Do you agree that in many people, that their GI tract is very sensitive to their emotions? Absolutely. I mean, think about test day at school. Yes, there's always somebody in every class who during a test says, jump up and run out of the room, right? Yes, diarrhea. Now, you may say, well, that never happened to me. Well, you may be the one it happens to at the NCLEX test, right? And the person that had the diarrhea all through school is already wondering this. So I always talk about this here. They're thinking in their head right now, what if, while I'm taking my NCLEX exam, I have to go to the bathroom and it's not a break time? What do I do? Easy. All you do is raise your hand very quietly, and the little lady is going to come over there to you, and you whisper to her, I'm about to have explosive diarrhea, okay? And they let you go wherever you want to go, whether it's break time or not. Just remember, your time is ticking every time you go to the bathroom. It's just something about the word explosive that gets people's attention these days, okay? Surgery can be done. For ulcerative colitis, they may take out your entire colon. Well, if they've taken out your entire colon, that's a total colectomy. And if they've taken all of that out, all you've got left is ileum, so we call it a ileostomy. Now, a very popular surgery, if you can find somebody to do it, is a Koch's pouch or a J pouch, okay? And the reason it's so popular is because there's no external bag. That's what patients don't like about the ostomy is the bag. They can't wear the clothes they want to wear. They're afraid it's going to fall off. They're afraid everybody can see it. Body image changes, that sort of thing. Well, with these procedures, the patient does not have to wear a bag because they have a valve they can open and close to empty their intestines, okay? And then also, the third one is where they can remove the colon and the rectum. In other words, take out the sick part and then just rehook up everything else normally. But even then, the patient still comes back with a temporary colostomy. A temporary colostomy. Now, here's a basic nursing concept. Anytime you've got a patient who has had a GI tract surgery, there's always a chance they might have a temporary colostomy. Why? To allow the intestines time to rest and heal. Rest and heal. And in the pediatric section, we'll be talking more about temporary colostomies there. Now let's talk about the surgery for Crohn's disease. First of all, they try not to do surgery. If they do, they may only remove the affected area. Well, if all of your small intestine's been removed and all you've got left is colon, that's why we call it a what? Colostomy. A colostomy. Now, let's talk about ileostomy care. Ileostomy care. And the first thing you need to know about an ileostomy is this. It's going to drain liquid all the time. That's just the way it is. It drains liquid all the time. That's why this patient is always a little bit dehydrated. They're always a little bit dehydrated. But the good news is this. It's never going to get clogged up. It is never going to get clogged up, so therefore it will never have to be irrigated. Never have to be irrigated. You don't irrigate ileostomies because they do not get clogged up. But we do emphasize that they are losing fluids and electrolytes with this. Now, the patient needs to avoid foods that are hard to digest and rough foods, because these kind of foods will increase motility and make the patient lose more water. That's not good. We want to limit motility. All right. So we've got somebody who's losing fluid all the time. We've already said they're a little bit dehydrated, right? They're always a little bit dehydrated. They're going to need Gatorade in the summer because they're sweating even more, aren't they? Yes, Gatorade, losing even more fluids and electrolytes. Now, tell your friend why the patient is always at risk for kidney stones. Why are they at risk for kidney stones? We've already said it, because they're always a little bit what? Dehydrated. Always a little bit dehydrated. Now, colostomy care. Regulation is through bowel training and irrigation. We irrigate colostomies, don't we? Now, don't get me wrong. Not all colostomies have to be irrigated. It just depends on the patient, and it depends on where their stoma is located in their intestines, all right? Now, what is the purpose of irrigation anyway? To empty out the intestines. To empty out the intestines. The same principles as like with an enema. We're trying to empty the intestines. And we're going to talk more about irrigation in just a second. Now, the further down the colon the stoma is, the more formed the stool will be, because what is being drawn out? Water is being drawn out. Water is being drawn out. And see on your handout, we've listed for you what the stool will be like, okay? If your stoma is in the ascending area, I'll bet that one is not going to get clogged up because it's liquid all the time, right? Yes, it's liquid. So no irrigation there. The middle one, the transverse, is the one people tend to have trouble with because it's in a spot that could get clogged up. All right? So we will most likely have to irrigate that one. And the third one, the stoma is so close to the rectal area, it's almost like normal bowel movements, okay? But there's always a chance that that one could get clogged up. I mean, think about it. Even people that don't have a colostomy get constipated, don't they? Yes, they do. And they have to take laxatives, same principle here. All right. People tend to not have as much trouble with the descending colostomy. Now, look at the next sentence. When is the best time to irrigate? Well, the first thing I want you to know is this. The same time every day. Same time every day. Because we're trying to develop a routine, aren't we? Yes, we're trying to develop a routine. And routine is very, very important because we're training the intestines to empty at a certain time every day, just like we do with spinal cord injured patients. Bowel training. So routine is very important. The other thing you need to know here is this. After a meal, because this is when everybody has the most peristalsis. This is when everybody has the most peristalsis, so therefore the intestines will empty more easily then. Now, if you've never done an irrigation on a colostomy, don't you dare go in the room and act like you've done this before. You ask the patient to show you what to do, all right? They'll be happy to teach you. They don't like it when people come in and try to act like they're doing something that they really don't know what they're doing. People are very sensitive about their stomas and their colostomies and ileostomies and urostomies, and many times they even nickname the stoma, okay? So I always ask, how can I help you? What can I do to help you? Show me what you want me to do. People love to teach. Now, when you're irrigating an ostomy, you use the same principles as if you were administering an enema. All right? Now, one thing you were taught about enemas is this. I'm talking plain old enemas. Your teacher told you when you're administering a plain old enema or giving somebody a rectal suppository to turn them on their left side. Okay? Left side. But that's not applicable here. That's if you have a rectum. If somebody's stoma's on their abdomen, you're not going to turn them on their left side. to irrigate, okay? Also, your teacher taught you principles like if they start to cramp during the procedure, your water may be too cold, or you're running it in too fast, so you need to lower the bag down or stop it altogether, okay? You use the same principles as if you were administering an enema, okay? Many times, people, if they're not too sick in the hospital, they do their own irrigations. And the further down the colon, the less you have to irrigate, because the more normal their bowel movements are going to be. Okay? The more normal the bowel movements are going to be. Now, if their stomach is really, really, really close to the rectal area, their intestines and their GI tracts almost just like normal. They may not even have to wear a bag over the area because they know when the intestines are going to empty. I mean, don't you know it when your intestines are about to empty or when you need to go to the bathroom? Yeah, same thing for that person. But remember, I said that's because their stomach is really, really close to the rectum, so that person has retained the bulk of their intestines, so everything's basically normal. Now, appendicitis is related to a low-fiber diet. And unless yours has already been taken out, you've got a little appendix, and it's just a little sac, and on your intestine, and can that little sac get filled with bowel contents? Yes. Can it inflame? Yes. And can it rupture? Yes. That's what I'm scared of. I'm scared it's going to rupture. That's the number one thing you're worried about, because if it ruptures, you're leaking bowel contents all into your abdomen. All right? All right. Let me ask you a question. What if you have somebody who has a perforated intestine or a ruptured appendix or something like that? You know you're getting them through surgery fast. So tell the person sitting next to you what position you would put them in while they're waiting to go to surgery. All right, you need to sit them up. You need to sit them up. And here's why. If they're lying down, the bowel contents is just going everywhere. You don't want that. You want to sit it up so the bowel contents will settle down in one spot. Settle down in one spot. Now, positioning. I just want to mention this before we go on. Positioning is one of the most important things you will do as a nurse. And a lot of times the doctor does not write the order for the position that he wants the patient to be in. So you need to get into the habit of when you walk into the room and see your patient, or you see your patient coming back from a procedure, you need to get into the habit of thinking, what position should I put them in? Because that can be a life or death situation there. All right? It's just like when somebody gets back from the bronch lab, you need to elevate their head and turn them on their side, right? So they won't aspirate. There's certain positions you put heart cath patients in when they get back, all right? If somebody's getting intermittent tube feeding, every time you go to give them a can of Ensure, you should turn them on their right side and elevate their head. I said turn them on their right side and elevate their head because if you're giving them a tube feeding, you want to put them in a position where their stomach will empty, right? Yeah, and you leave them in that position for at least 45 minutes after you've given them the can because you want to make sure you've given their stomach time to empty. We're trying to prevent aspiration is what we're trying to do. Now, what do you do if you've got somebody who's got a tube feeding going and you need to turn them maybe and get them pulled up in bed? What should you do with the tube feeding first? Stop it. Stop it, and you better check it for placement again before you start it up again. All right, now back to appendicitis. Let's look at our signs and symptoms. It is generalized pain initially. In other words, just kind of aching all over a little bit, no big deal. But you know, the closer it gets to getting worse, I should say, or becoming more inflamed, it starts localizing in the right lower quadrant, okay, known as McBurney's point. McBurney's point. You go to the ER, and the first thing they're going to do is get a CBC on you and see what kind of trouble you're having. Well, your white count is going to go up with appendicitis. That's one of the main things they look at. Then nausea and vomiting can occur, and then there's that rebound tenderness again. The ER doctor consults a surgeon, and the surgeon comes in and checks out the patient and everything and says, yep, it's appendicitis. We need to go to surgery. Nurse, give a cleansing enema. What do you say? Say, I'm scared. That goes over better than no, okay? You're scared. Why are you scared? Because you could rupture the appendix. They do not want a new nurse giving an enema pre-op here because the appendix could rupture. That's a high-risk procedure. Now, don't get me wrong. In some med-surg books, it will say that enemas are administered preoperatively. But do we want a new nurse doing this? No, they don't want a new nurse doing that. So you hurry up and go get somebody that's already got their license and let them do it, okay? Now, after any major abdominal surgery, what is the position of choice? You elevate the head a little bit. You elevate the head a little bit. That's going to decrease pressure on the abdomen. It's going to decrease pressure on the suture line. Decrease pressure on the suture line. Now, peptic ulcers. You may not have had an ulcer before you went to nursing school, but you may have one now. It'll get better when you pass boards, okay? It's a common cause of GI bleeding, and it can be in the esophagus, the stomach, or the duodenum. Now, is it mainly in males or females? Males, but increasing in females, and erosion is present, and that erosion can lead to burning pain, usually in the mid-epigastric area, and sometimes the patient will say that the pain shoots all the way through to their back, okay? Now, it doesn't always have to be pain. The patient may say it's burning there, or they have a gnawing sensation there, or sometimes they say, I just feel hungry right in that little spot right there, and I just ate 30 minutes ago. Now, antacids are used. Do we prefer liquid or tablet here? Liquid, because we want to coat the stomach. We want to coat the stomach. If we can coat the stomach, that's going to protect the ulcer, isn't it? Yes, it's going to protect the ulcer. I do not want acid to get on the ulcer. That's going to make everything worse, okay? Now, it also says here that we're going to take when the stomach's empty and at bedtime. Well, that's weird, because normally when people take an antacid, it's after they have eaten something that has upset their stomach, okay? But here it's different. They want us to take it when your stomach's empty and at bedtime, because when your stomach's empty and at bedtime, during the night, your stomach's going to get empty. That's when acid can get right on your ulcer and make things worse. And we want to protect the ulcer. We're protecting the ulcer from the acid. Also, we have listed some protein pump inhibitors, H2 antagonists, and a GI cocktail, which is mainly given in the ER, okay, for discomfort. You can even buy some of these drugs over the counter and treat yourself, which can be dangerous because it's hard to treat an ulcer. And chronic irritation in the stomach is not a good thing. You need medical help. Other treatments are antibiotics for H. pylori, such as Biaxin, amoxil, tetracycline, Flagyl. Now, H. pylori is the name of the bacteria that can cause many stomach ulcers. Carafate can be given because carafate forms a barrier over the wound. So what can't get on it? Acid. We don't want acid on it. Have you ever seen a doctor that wrote an order for a carafate slurry? Not a Slurpee, a slurry, I said. All right, that just means it's going to be liquid carafate. You can give carafate as a pill or a liquid. They need to decrease stress, stop smoking, eat what you can tolerate. They used to say to eat a real bland diet and drink a lot of milk. Well, they found now that that's wrong because milk makes you have more acid, which makes ulcers worse, okay? So now they say, hey, you know what makes your stomach hurt? Don't eat that, okay? Eat what you can tolerate. They also tell you to avoid temperature extremes in foods and extra spicy foods. Avoid caffeine. Caffeine is an irritant. Caffeine is an irritant. And then they will need to be followed for a year because it takes a while for an ulcer to get well, okay? People don't do that. They borrow some of their friends' Nexium one day and their stomach starts feeling better and they think they're well. And so they stop taking the Nexium and then a month later, guess what? They're hurting again. It takes a while for an ulcer to get well in that acidic environment. All right, now let's differentiate between gastric ulcers and duodenal ulcers. Gastric, these are your laboring people. They're malnourished in appearance. Pain is usually a half hour to 1 hour after meals. Food doesn't help, but vomiting does, and they vomit blood. So here's the deal. Every time they eat, they hurt, so they go and make themselves throw up. Well, naturally, if you're making yourself throw up, you're going to lose weight, aren't you? That's why they have a malnourished appearance. Now let's look at the next one, the duodenal. This is your executive type. They are well nourished and nighttime pain is common in 2 to 3 hours after meals. And food helps and they have blood in the stools. So this person, every time their stomach gets empty, they start to hurt, don't they? Yeah, when their stomach gets empty, they start to hurt. So they get up and get something to eat, even if it's in the middle of the night. Well, if you're eating all night long, naturally you're going to gain weight now, aren't you? Yes, that's why they have a nourished appearance. A nourished appearance. The next thing we have is dumping syndrome. Dumping syndrome is when the stomach empties too quickly and the patient experiences many uncomfortable to severe side effects like fullness, weakness, palpitations, cramping, faintness, diarrhea. Now tell your friend, after what surgeries do you get dumping syndrome? Gastric bypass, gastrectomies, gastric bypass or gastrectomy. And you can also get it with gallbladder troubles too. Now remember, in the oncology section, we studied stomach cancer and gastrectomy, right? We said that they did a gastrectomy where they debulked. They took out a lot of the stomach to debulk the tumor and left the patient with a little 30cc pouch so they can continue to eat and drink with some degree of normalcy. And then that stomach cancer patient starts going for their chemotherapy, all right? Well, they get to the doctor and their blood counts are not high enough, so they can't have their chemo. And the doctor says, go home and eat now. Eat plenty because we got to get your blood built up so we can give you your chemo. Well, if every time you eat, you get symptoms like that, are you going to want to eat? No, you do not want to eat. So we've got to help this patient some way, all right? First of all, treatment, semi-recumbent with meals. In other words, you want them to lie back a little bit. Lie back a little bit, I said. Now, not so far back they aspirate. But you want them to lie back to try. Here's the deal. We're trying to keep the food in the stomach. We're trying to keep the food in the stomach as long as we can. Trying to keep the food in the stomach. And then after they get through eating, they need to lie down. After they eat, they need to lie down. Now tell your friend what side you want them to lie on, left or right. Okay, we've already said that when you want their stomach to empty, you turn them on their right side. But here, we're trying to keep the food where? In the stomach. In the stomach. So you turn this person on their left side to keep the food in the stomach. Left side. No fluids with meals. They have to drink their fluids in between meals. In between meals. They need to decrease their carbs simply because carbs empty really fast. Carbs empty fast. Now the next thing we have to talk about is a hiatal hernia. This is when the hole in the diaphragm is too large and the stomach moves up into the thoracic cavity. Now, y'all, is it normal for your stomach to be living up here with your lungs? No. So, of course, you're going to be sick, right? They're not supposed to be living together. Now, let's understand something before we go on. One of the major causes of a hiatal hernia is a large abdomen. That pressure in there, pressure, abdominal pressure is pushing things up, opening up that hole that your stomach, that your esophagus is supposed to go through. But now your stomach is being pushed up, back up through that opening, all right? So, of course, the patient is going to get symptomatic. And one of the first things the doctor is going to tell the patient to do is lose weight. Well, we all know how hard that is, right? Now, other causes of a hiatal hernia include a congenital abnormality, trauma, or surgery. So other things can cause it too. All right, now signs and symptoms. Heartburn, fullness after eating. In other words, they get full quickly is what I mean. They get full quickly. And regurgitation and dysphagia can occur. Regurgitation and dysphagia. Do you think this person has a lot of trouble with reflux? Yes. They also have a lot of trouble with reflux too. Now, treatment. Small meals. If this person eats a big meal, that's when they're about to get really symptomatic. Okay, so small meals, and this person needs to sit up after they eat. They need to sit up. Why? To keep the stomach down. To keep the stomach down. If I go in and eat a big meal and then lie down and I have a hiatal hernia, where is my stomach going? Up. All right, that's not good. That's when I'm going to get symptomatic. Also, elevate the head of the bed. I'm talking about even at home. They need to elevate the head of the bed. Okay, they'll have those concrete blocks under the head of the bed. Because when do you think this patient becomes most symptomatic? Nighttime, when they're lying down. When they're lying down. Well, anytime they lie down, they can become symptomatic. Anytime they're lying down, they can become symptomatic. And surgery can be done, but if you still have that really, really large abdomen that I was talking about earlier, the problem's just going to recur, all right, because of all of the pressure. Now then, we have hyperalimentation, total parenteral nutrition, all right, TPN, whatever you want to call it. Now, some doctors might write an order for PPN, peripheral parenteral nutrition. So different, you'll be able to recognize it in a test question, what it is, okay? Keep refrigerated, warm for administration, which just means you set it out on the counter a little bit, right? Yes. And a central line is needed because is this stuff packed with particles? Yes, it is packed with particles. And particles eat up peripheral veins. Particles eat up peripheral veins. So we want a central line, don't we? Yes, we want a central line. Now, I know some of you have seen it given peripherally. Do not pick that on boards. It will be wrong unless it were a PICC line, a peripherally inserted central line. That's different, okay? Because the PICC line, the line's going all the way up to the right atrium of the heart. That's different than a peripheral line out here in my hand or arm, okay? Now, we're going to utilize a filter. And nothing else should go through this line. It is called a dedicated line. A dedicated line. Remember, there can be several ports that can be used on a central line, but nothing else needs to be mixed in the same port with the TPN. Don't mix anything in the same port with the TPN. Now, I know there are new things out there in the world that you can mix with hyperal, but we're not going to do it because we're new nurses. All right? And on your CD that you have, there is a document on there about central line care you probably need to review. All right? Now, when we discontinue hyperal, we do so gradually to avoid what? Hypoglycemia. Hypoglycemia. Never just go in the room and just turn it off. When a doctor writes an order, DC hyperal, they mean to taper it down, okay? Taper it down. If you go in the room and just turn it off, what is going to happen to their blood sugar? drop out the bottom. Daily weights. If I'm on Hyper-Al, do you want me losing weight? No. If I'm losing weight, I don't think my Hyper-Al is working like it should. And I may have to start taking what? Insulin. Insulin. Check the urine. Now tell your friend what you are checking the urine for. If you did check the urine, you would be checking it for glucose and ketones. Glucose and ketones. What about protein? No, no, no. Protein won't work here. We've already said that the only time that people have proteinuria is when they have glomerular damage, okay? We haven't said this person had glomerular damage, all right? So glucose and ketones. Now remember, if somebody has glucose in their urine, that means their blood sugar must be really, really, really high, right? If somebody has, and they need insulin, by the way, if their blood sugar's high. If somebody has ketones in their urine, that means they're breaking down body fat. Is that good or bad? That's bad. If you've got somebody on Hyper-Al, you do not want them breaking down body fat. The Hyper-Al's not working. That person might need some lipids or some fat emulsions to try to help them to stop breaking down body fat. AccuChecks will be done every 6 hours because we're monitoring their blood sugar. Hyper-Al is never mixed ahead of time. Besides, you and I don't mix it anyway, right? The pharmacy mixes it, but we don't mix it. They should not mix it ahead of time because the mixture can change every day. Yes, the mixture can change every day according to my electrolytes. According to my electrolytes. We're going to be looking at the electrolytes every day. And that's the first thing the doctor's going to want to look at when they get there in the morning because they may need to change the mixture. They may need to change the recipe. And when you get that new bag of Hyper-Al to the floor, you might as well just go get the bag of fluid and the doctor's order and sit down because you've got to compare each ingredient to make sure the pharmacy tech has brought the correct bag of fluid. Because they all look the same, don't they? All right. The TPN can only hang for 24 hours, and the tubing needs to be changed with every new bag of TPN. And the IV bag may be covered with a dark bag to prevent chemical breakdown. All right? Maybe, I said. It needs to be on a pump. And with home TPN, we emphasize hand washing because the most frequent complication is infection. The most frequent complication is infection. Now, this might be your opportunity to help the doctor put in a central line, okay? So you need to have some saline available for flush. And a common order or rule of thumb is to have 3 10-milliliter syringes ready, okay? Because most of your central lines are triple lumens, so you need some saline for each port, to flush each port, okay? Now, do not start fluids until positive confirmation of placement by chest x-ray, okay? So they're going to do a chest x-ray to make sure they've got this in the right place before we ever start fluids. But we've got it flushed out so it won't clot off. Now, tell your friend what position you're going to put this patient in for central line insertion. The most common position. All right, now listen to me. When you start an IV in my hand, what do you put on my wrist? A tourniquet to distend the veins, right? Yes, a tourniquet to distend the veins. But y'all, you're going to get fired if you put a tourniquet up here on somebody, aren't you? Yes, that's not good. So what position do you put the patient in? The most common position is Trendelenburg, to distend the veins. Trendelenburg, to distend the veins. Now, I know somebody's saying right now, well, I saw a doctor do that one time and he didn't put them in Trendelenburg. Well, we're learning what the most basic standard of practice is, and Trendelenburg is the best answer there. Now, you will need to get somebody to come and help you with this procedure when you're assisting a doctor with this, because you're going to need somebody to stand at the head of the bed and hold the patient's head still, okay? Normally, they turn it away from the site where they're doing the insertion, okay? So a lot of times the patient will move around. And don't forget the patient's hands, okay? Because when the doctor sticks here or here, the patient could, just by reflex, reach up there because it hurts. So don't forget their hands. You don't want them reaching up into the sterile field. And remember, the patient's scared. They've got the big blue thing over their sterile field, over their face, and somebody's got their head turned like this and their hands tied down. Talk to your patient and reassure them and let them know that everything is okay. Now, if air gets in the line, what position do we put the patient in? Ask your friend. All right, the first thing you've got to do is think about where the line is going, okay? It's going into the right atrium. So if an air bubble gets in the right atrium, it's going to go right atrium, right ventricle, and down into my lungs, okay? That's not what you want to happen. You've got to do something to prevent the forward flow of that bubble. So if you sat the patient up, you just help the bubble get down to their lungs, and now they're sitting up in the ICU on the ventilator with their pulmonary embolus. That's not nice, okay? So the answer I want you to select here is to turn them on their left side. Left side. And the reason for that is this. Here's my right atrium, okay? You turn me on my left side, and hopefully the little bubble will float up and out here. Air floats up, okay? It will not go forward. Don't get me wrong. I don't like air bubbles out in my arm either. But at this moment in time in my life, if I had to pick, would I rather have the air bubble in my arm or in my lung? In my arm. Hey, you're going to work with people who say, oh, don't worry about that air bubble. It takes a whole tube of air to kill somebody. And you know what the next thing you should say is? How do you know that, right? Yes, I want to know how they know that. You always worry about air bubbles. Always worry about air bubbles. Now, so left side. Now, there's another option you can pick here too. Left side Trendelenburg. Left side Trendelenburg. Left side Trendelenburg. Well, y'all, that's the most perfect position in the whole wide world, isn't it? Yes, left side Trendelenburg, because that'll really make that air bubble float out of my right atrium and not let it go forward, okay? When you're changing the tubing, how can you avoid getting air in the line? Well, the first thing you think of is, we'll clamp it off. Well, everybody knows that, so it'll never be an option. But you can manually clamp it off, or it may have clamps on it, okay? But let's say that's not the answer. That answer is not an option for us to choose. What can you have your patient do? Well, you can tell them to take a deep breath and hold. Take a deep breath and hold. Valsalva. Valsalva. Now, y'all, people don't know what Valsalva means, so you need to tell them to bear down like they're about to have a bowel movement, okay? That's what Valsalva is. Or you can say, take a deep breath and hold, or hum. They need to hum, because when you have somebody who's humming or doing any of those things I just mentioned, you are increasing intrathoracic pressure. You're increasing intrathoracic pressure. Well, if your intrathoracic pressure is great, can air from out here go in against the pressure? No, air cannot go in against the pressure, okay? Now, why do we do an x-ray post-insertion? 2 reasons. To check for placement, and to make sure the doctor did not cause a what? Pneumothorax. Make sure the doctor didn't cause a pneumothorax. If you've ever seen somebody, especially a new resident or whatever, trying to start an IV or central line, especially subclavian, sometimes they poke and they poke and they poke, and you wonder if the needle is coming out the backside of the patient. Yes, the lung could be punctured. All right? So we're going to be sure and get a chest x-ray. All right? Now, what's the hardest thing about getting somebody in Trendelenburg? Figuring out how the electric bed works. Yeah, figuring out how the electric bed works. So let me tell you from personal experience, if you have a doctor that's coming to put in a line and the patient has an electric bed, you need to practice with the bed ahead of time, because I've had the bed doing like this and the doctor's standing there waiting for it to stop. That's embarrassing. Don't let that happen to you. Practice ahead of time. Now, the last thing we have printed on your handout is the proper way to flush a central line, just for your enjoyment. Do you see that there? Push pause. When administering meds via a central line, this is the technique that should be used with the flush. And the smallest syringe you should use with a central line is 10 milliliters, because anything less than this would exert too much pressure, which could lead to catheter damage. Okay, so you're using the push pause. You don't want to push too vigorously. You push and you pause and you push and you pause, because if there is a clot on the end of the line, if you're too vigorous, all right, it could dislodge the clot off the end of the line. Also, you don't want to give it too fast, because you don't want to bolus the patient with their medicine either. And you got to flush because you want to maintain patency of the line. You don't want clots to form on the end of it. All right, that's your GI system.